Welcome to the Global Public Health Revolution, the podcast by the AIDS Healthcare Foundation, where global public health meets bold advocacy and game-changing marketing to spark real change. I'm your host, Kemi Gbadamosi, and together we'll explore how storytelling, innovative campaigns, and disruptive strategies are shaking up global public health. We'll talk to experts, policymakers, and grassroots mobilizers who are pushing boundaries and rewriting the playbook on public health advocacy. So, if you're ready for fresh ideas, game-changing conversations, and a bit of fun along the way, you are in the right place. Let's dive in. This is the Global Public Health Revolution podcast, where global public health meets bold advocacy and game-changing marketing. I'm your host, Kemi Gbadamosi, and together we'll uncover the power of storytelling, creative campaigns, and disruptive strategies that spark real change. For this inaugural episode, we're diving straight into the state of global health and the way forward. What lessons can we learn from the HIV/AIDS response? And I'm honored to be joined by Michael Weinstein, the president and co-founder of the AIDS Healthcare Foundation, AHF, the world's largest AIDS organization operating in 48 countries and currently providing care and services to over 2.3 million clients. And on today's discussion, we'll explore regional approaches, innovative health financing, the need for a new public health architecture, and how civil society participation can drive health equity and resilience. Stay tuned. This is a conversation you do not want to miss. Hi, Michael. Welcome to the Global Public Health Revolution podcast.
I'm very happy to be here, Kemi.
I'm excited to have you here for this inaugural episode, and that's just because of where we are today in the world when we talk about the state of global health, from shrinking donor funding to freezes or even just closing out of programs and projects. And I think this is just the right time to have this conversation, especially with someone as yourself who has a lot of experience leading a global organization. And I would say basically you've seen it all in terms of public health and the HIV response. So I'm very excited to have you on the podcast today to discuss this. If we could just go into setting the scene, how would you describe the current state of global health, and what gaps has it exposed, and what opportunities does it present to us?
We are in crisis, but the crisis is not new. We have been in crisis for an extended period of time. I mean, I particularly go back to the Ebola outbreak in 2014, where it was grave concern, a disease that had been regional, becoming global. And for AHF, we lost our doctor in Sierra Leone, who was the only virologist in that country. But we've seen a number of crisis situations, of course, the gravest of which has been, recent times, has been COVID. And, there was a lack of coordination, and, the response was, grossly inadequate on a worldwide basis. So current crisis that's going on in terms of the loss of donor funding, has real world consequences. There will be people who will die and good projects that will be discontinued. But prior to that, there was still a need for a total restructuring of global health architecture. If there's a silver lining in what's going on now, it may be that we accelerate those conversations.
You raised something very important where you talk about the fact that there is a silver lining, but at the same time, some of the losses that we have recorded, including AHF losing one of its doctors during Ebola, as well as the fact that every crisis provides an opportunity to reimagine, maybe in this instance, how health is done. It brings me to mind to COVID-19, which you also hinted. And then it's been 40 years of the HIV/AIDS response. What are some of the lessons that the world needs to learn from COVID-19, HIV/AIDS in addressing the ongoing global public health challenges that we're seeing?
AIDS has been a rare exception, a rare success on a global basis. And despite the fact that tens of millions of people have died of AIDS, there was a global mobilization on a scale we have never seen before. And that has resulted in a drastic reduction in new infections and a drastic reduction in deaths. I mean, when you look at a country like Malawi, where the life expectancy has gone from 46 to 65 over these last 20 years. And that's a remarkable accomplishment. And there was a unity of purpose in terms of combating AIDS on a global basis that we've seldom seen before. And when COVID first broke out, and I was sitting on many different panels, first of all, I would remind people when people said we haven't had a pandemic like COVID since the flu, I reminded them that AIDS is both a pandemic and also has been the bigger killer than COVID, which is not to understate the significance of COVID. COVID exposed three major weaknesses in the global health structure. First is transparency. So you can't respond in real time when you don't know that an outbreak is taking place. And there's ample evidence that that information was withheld by the Chinese so that the spread was much wider at the early stage of the pandemic. And second issue was accountability. You have things like the Atomic Energy Commission, or you have air traffic control, or World Trade. There's a rule book, and everyone is required to follow by the rule book if they want to land planes or they want to participate in the global community. No such thing exists when it comes to infectious diseases and public health crises of this kind. And the third thing that it exposed was lack of a system of coordination. So essentially, it was every country for themselves. The countries, rather than sharing information or sharing goods, it was every country for themselves. And so that meant that the rich countries hoarded vaccines and other supplies. Perhaps a silver lining, again, in this was that Africa kind of led the world when it came to cooperation. And the African Union, the Africa CDC, was able to coalesce the 54 countries in Africa and have them coordinate their activities. And that's not the only reason why COVID didn't hit Africa as hard as was anticipated, but I think it did help.
Thank you, Michael. You raised some really key points I want to pull out because it's a good segue into the next question. You talked about Malawi and how its life expectancy has increased, but also the unity of purpose, which is very crucial in responding to health crises. And the fact that AIDS has been here for a longer time, even before COVID, and has even killed more people. And then something that you also talked about was highlighting the role that the African Union and the Africa CDC played when it came to mobilizing the continent to respond very decisively to COVID-19, despite the fact that there were inequity issues such as access to vaccines. And so it brings the question of, do you think that regional approaches or institutions is the way that we should go globally, especially when it comes to building resilient and equitable health system in the new world order that we see?
Yes, I mean, first of all, we, of course, focus on global pandemics like COVID that hit every corner of the world, but there are many severe crises, public health crises, that never go beyond a region. That's very, very important. Another thing is that we have to understand the importance of culture, integrating our messaging and our mobilizations into the culture. And that's, of course, varies very differently by region, by country. Even within a country, there are many different cultures that have to be taken into consideration. For example, in case of Ebola, the response was very haphazard in West Africa. The population was not trusting what the government was saying. In Sierra Leone, they declared a shutdown and required everyone to stay at home. And they turned to civil society to go out into the community and deliver messages against pushing bodies of corpses, etc. And it worked. After 3 days, things fundamentally changed. But the other aspect of this is that in the broader historical context, we're still living with the consequences of colonialism. And the developing world, they're looked at for extraction of minerals and other natural resources, rather than investment. So aid that's given is really in order to cement the economic position of the wealthy countries in the poorer countries. And so that results in, continuing impoverishment. A lot of the programs that exist are done as loans, so that increases the debt burden. And then the debt service is competing with health and other social expenditures. So I think that while the aid programs have saved lives and are important, to agree they perpetuated a system where the poor countries were not self-reliant, where these aid programs are laying down certain guidelines or rules which the countries have to adhere to if they want the aid, but may not be appropriate. So yes, this is a crisis, and yes, the abrupt termination of so much of the aid is causing hardship and discrimination. I think also that in a situation where you had kind of the world divided into donors and recipients, aid to these global bodies like WHO and the World Bank, et cetera, the developing world was not able to assert its power because it felt that it had to placate, the donors to continue to receive those funds.
I want to unpack a bit. You mentioned about culture and context, really. I just wanted to dig in a bit into AHF's experience, because given the fact that it's a global organization that works in countries from across Africa, Asia, the Americas, Latin America, and the Caribbean, I wonder if you have something to share in terms of AHF's experience on how it has leveraged or its sensitivity to the culture, to the context, or how it has also leveraged local opportunities to strengthen HIV/AIDS response, because I think there is a lesson there to learn, even as we talk about strengthening regional approaches or institutions.
When we opened our first clinic in a shopping mall in South Africa in 2000, our neighbors to the left and right were a funeral home and a natural healer. At first, the people coming in from the north were kind of somewhat trashing traditional healers and saying that opposition to administering ARVs. But what we found over time was that we could enlist their help, and that actually a lot of the traditional healers were willing to say, come to me for these illnesses or issues, but they'll go for ARVs, right? And that's just one example. But I think that there's been some positive work done with religious institutions, I think, in winning them over to prevention. But also, I remember being in Kenya. We were doing a testing outreach. We had set up our tents. We were in this big open field next to a very poor slum. And I was saying to one of my colleagues, I said, we're all set up with this big thing, but there's nobody here. Don't worry. When the music starts, the people will come. And sure enough, the music started, and it was like around dusk, right? There were hundreds and hundreds of kids, right? Well, these are just children. I said, we're trying to test adults. I said, don't worry. When the sun goes down, the adults will come. And so they did. And people who are poor, they can't pay for entertainment. They can come and listen to music and dance with other people. It worked. There were so many places in the world where we did testing. And people said, oh, nobody will come out in India and sit down in the line to be tested. They'll all be too embarrassed. We did it, and we saw, women in traditional saris, younger people, older people in huge numbers, right? We set up in the metro station in Mexico City, and the government was up in arms. You can't do that, and privacy and the like. All the caution about privacy has basically been wrong. Almost anywhere in the world that we have set up shop to do testing, people are willing to come out in public. Not everyone, but a large segment of the population. And then there's when we've had local artists, I think about an artist named B-Flow, and I first ran into him when he performed at a open house that we had for ribbon cutting for one of our new facilities. And then we engaged him, and he wrote songs that were specific to being tested for HIV. He had a beautiful, I don't want to lose another brother, I don't want to lose another sister. So you can turn people out to cultural figures who will appear in a video or will be on a podcast. The other thing, too, culturally, is that in the West now we have streaming and we have satellite radio. Out of the world, it's still very much local FM stations. And they're hungry to have guests, right? They're
absolutely hungry. Yeah.
And it may be a very limited geography, but for example, we had broadcasts in very large market, Kampala. And it didn't reach, much beyond the market, but in the marketplace, there were 20,000 vendors, right? And 100,000 people a day came to shop. And since we were there, we were, very much part of that community, it was very, very effective.
Thank you very much, Michael, for sharing those experiences, because what I hear is the need to tap into the locals, the communities. There is a lot there, even as the world navigates, or as continents navigate the new world order. It's also to look into communities. But there was also something you had highlighted. It was in terms of implementation. A lot of times, donors basically dictate what should be implemented rather than going with what the needs are on the ground. And I think the lessons you're sharing from AHF's history, it lends credence to the fact that there is a need to trust the capacities on the ground, as one of the ways to make health more equitable is to work with the capacities on the ground, whether it's religious figures or cultural icons or even celebrities, and tap into the diverse platforms that we have to make sure that more people are being reached with health information, whether it's prevention, when it comes to HIV or services. I think that's very important as communities continue to debate how do we move forward in this world order. It also brings up the point, you touched on it a bit, about investment. You talked about health as an investment, but all over the world for a long time, people see health as charity. That has been something that has driven even development assistance, that's driven donor funding, or just how health is perceived. And so my question would be, how do we shift that narrative of health as charity to drive more sustainable and innovative financing, both for HIV and just broader public health services?
Well, I reflect on the experience with AIDS, which was that who was AIDS attacking in sub-Saharan Africa? Young people mostly, right? I mean, so you had the situation of many orphans. That's very bad economically. You had the situation of the able-bodied people in a family dying off, and some of the older people having to both take care of grandchildren, which they were not always equipped to do, or just elderly people as they got older, got ill and died, created an enormous hole, right? And the sub-Saharan African countries were suffering tremendously economically from that. So also, the reality is, in the development process, social needs determine whether a society is a modern society, right? So just, for example, if a person who's working at a job in Zimbabwe, right, has to go to a public clinic and spend the entire day there in order to get a simple health need met, right? That's tremendously disruptive. But also, the reality is that, Rwanda is experimenting a very interesting system where they have instituted insurance. And that's going to do a variety of different things. It's going to improve health outcomes. It's also going to spawn a bunch of health facilities that are not dependent upon government funding or aid. So a system based upon charity is always going to be based on scarcity. It's always going to be based on rationing. All of the wealthy developed countries in the world have systems that are integrated into their economies, guarantee to one degree or another access to healthcare.
All right. So AHF has a history with communities and then also civil society. And it is a champion when it comes to advocating for whether it's HIV or public health. And I'd like us to talk a bit about civil society and community voices. What role can they play in the global health agenda? Especially now that we know that there are shrinking spaces. We see a lot of global health discussions happening around the world, or whether it's agreements that are being put in place or declarations that countries are adopting. But we don't seem to see enough civil society voices in those spaces that are very important. Just drawing from AHF's history, how can we change that? What can we do to make sure that there's more representation of civil society and communities in these spaces?
Well, first of all, I think that people forget the public in public health. I mean,
I like that.
the discipline of public health is about disease control. The medical system is to treat the individual. Right? And the other significance of public and public health is that public health relies on the voluntary participation of the public in order to prevent and to deal with infectious disease outbreaks. So too much of global public health has been top-down. Edicts from, Geneva or other places, telling the world what to do, with little consideration to local buy-in. I just wanted to give one example. We opened the first rural HIV clinic in Uganda, very heavily impacted by AIDS. And we did it at a regional tertiary hospital. It wound up being like a beacon of hope. Thousands and thousands of people flocked to us. It cooperated very, very well with the hospital, and it caused vast improvements in the hospital itself. Program funded by the U.S., a PEPFAR, opened up a clinic across the street, across the road, and yet in this vast region of Masaka, there was barely any coverage beyond in the town itself, right? Example of the duplication and the waste of resources. So the planning needs to be done at the local level, then national, et cetera. I also want to say one of the reasons why AHF has had so much success in this regard is the fact that we made a fateful decision on day one that we would staff our programs with local people. Not only is that great from the point of view that they understand the local culture and they're of the people locally, but also we have developed a vast management capacity, which is contributing to the national brain trust as opposed to the brain drain that's taking place. People leave the developing world, go to countries. So I think those are all things to consider. But as far as the civil society itself,
Yeah.
I think it goes both ways. I think that civil society has, to a degree, isolated itself from the operational needs. It has advocated for civil society in a fairly narrow way. So, very often civil society has been advocating for funding for their services, looking at the bigger picture. Also, many times they've been dominated by the country's voice, not had an independent voice. I think there's a need for civil society to have greater economic independence from the government. I think that's very, very important. I think also that a lot of times civil society has been co-opted by the donors. So if somebody is running a successful NGO, then the donors from the rich countries come in and hire that person away. Problem has been that these funded programs, donor-funded programs, they're not paying the wages that are paid in these countries. They're paying multiples, 3, 4, 5, 10 times as much. And so that, again, causes that brain drain away from locality. But there's also a need for accountability. There's a lot of what we call briefcase NGOs.
Yeah.
Applied to create an NGO, not because of commitment to a mission, because it's an angle to make money. So there has to be accountability. I think also that the NGOs have to make it clear to government that they're not there to overthrow the government. They are not terrorist organizations. They are there to partner with the government to improve the services and to improve circumstances. I think there's a gray area of NGOs that are really about corruption and democracy. I think that the service NGOs in the health and education and other sectors, social sectors, really do best when they steer completely clear of politics.
Absolutely.
It's one thing to go to the government and say, the minister is corrupt and the minister is political appointee and the other party should be elected, right? That's going to be a problem. But if you're going to the government and saying, we believe that you can stretch your resources by doing it this way rather than that way, or in the clinics that we work with, we believe that you could be efficient and effective if you would invest a small amount of money in an electronic medical record.
Yeah.
Things do what, trigger those responses. Government overall is suspicious of anything it can't control, right? There's a natural suspicion of NGOs, but I think that can position themselves in ways that are not political, trigger that response. And I think AHF has done that well. We operate in countries that are having civil wars like Myanmar. We communist countries. We operate in countries at war, like Ukraine. We operate in countries like Haiti, where the gangs run the country. And yet we're still able to provide services and we're still able to make advocacy changes.
I like when you said people often forget the public in public health. I think that will be very good for a placard, especially for civil society, or a good talking point for civil society to use to advocate for the significance of civil society and communities in the global health agenda, because it is true, there's no public health without the public. But you've also highlighted very key nuggets that civil society can benefit from to strengthen how it engages even in the global health agenda. You've talked about the need for economic independence. You've talked about civil society not getting political, staying away from the politics, building trust with government by reassuring government of the fact that they're there to improve. NGOs are there to improve, to support what government is already doing and not trying to take away from that. And then you also did highlight the fact that accountability is also very key, and it goes both ways. I believe that any civil society organization listening to the podcast will take that away as a way to rethink, even as we move forward, how civil society shapes its engagement. And I hear you when you talk about the isolation, because sometimes civil society can be so focused in its own needs and not looking at the bigger picture. So thank you for pulling that out in your submission. We're coming to the end of our conversation, but we do have a fun part of this podcast, which we'll come to a bit later. But I just wanted to, just looking ahead from everything you've shared, from your experience, from the work that AHF does, and just being also a very significant figure when it comes to public health and HIV/AIDS response globally. What bold shifts do you think that the world needs today when it comes to policy, funding, or even community engagement to achieve a new global public health architecture?
People need to understand the obvious point that diseases do not respect boundaries. You can't have Fortress Europe or Fortress America, Fortress China. Diseases will spread. I mean, essentially, COVID touched every single person.
Mm-hmm.
Every single person on the planet ultimately was exposed to COVID. I think the message is that public health is really cheap. An ounce of prevention is worth a pound of cure, but also that small strategic investments can have such a huge, huge benefit. In the biggest picture, we need to elevate public health into the pantheon of issues in the world. That is, such as peace, poverty, women's rights, the things that the world recognizes, climate, have to be embraced on a global basis for the world to improve, or maybe even for the human population to survive. Until or unless we do that, we're going to continue to have these scourges. And the world has shrunk. Mass migration, the mass travel, we're in a situation now where diseases can spread very easily and rapidly. The things that we care about the most, we mandate cooperation. We have a rule book. If you want to land planes in our country, this is the rules for air traffic control. If you want to participate in the global trade, the WTO says these are the rules. And that's what we need. We had a moment in COVID where it looked like that's what we would do, where we would have that overarching set of guidelines. And that moment passed, unfortunately. So now we're looking at a convention, pandemic treaty convention, that is going to be very weak and prevent another crisis of the magnitude of COVID, or worse than that. I think the progress that's been made is that we've been able to change the dialogue. We're not getting the actions we need, but we've introduced the idea of a global public health convention. We have introduced or increased the notion of accountability, of cooperation, transparency. But in the meantime, we have a lot of work to do. We have a clear agenda to meet. For AHF, we're putting a lot of our stock in the regional approach. We think, first of all, the way of the world right now is that the developing world has to take its future into its own hands. It has to assert itself and has to end the vestiges of colonialism, pool its resources and its power. That's one aspect. And also that the people in community can be mobilized to help. We need them desperately.
Thank you, Michael. Very strong points here on, and I think it's a close ending, a strong closeout as well to our conversation on the state of global health. And that's just looking at making small strategic investments, elevating public health and changing. We've done a lot in terms of changing the dialogue. And now we need to hone in more on accountability, on cooperation, transparency. I also like that you highlighted the regional approaches as one of the ways forward that the world should look at. And then also the developing world needs to take its future in its own hands and assert itself. I think that's a very strong message and a strong call to action there, especially when we look at the impact of colonization on even health and just how positioning itself, because it is the developing world is very important. And so thank you for highlighting that. And then also you talk about communities and how they remain critical, even as the world in global health, public health. We've seen that work even during HIV response. I think there's a very strong call to action for not just our listeners, but even for governments and decision makers, as well as communities as well. So thank you very much for sharing from your experience on this inaugural episode of the Global Public Health Revolution podcast. So I want us to go to the fun part. And this is an opportunity for our listeners to get to know you a bit more. They know you as Michael Weinstein, the president and co-founder, but I also understand that you are a movie buff.
Yes.
Great. Could you give us like a rundown of your 5 all-time favorite movies? That's the first part of it. So we'll start with that one.
It was hard. I had to narrow it down, but these are the 5 that I came up with. Godfather.
Okay, I like Godfather.
Devil Wears Prada.
Oh, I like that one too.
Brokeback Mountain. Schindler's List. And Out of Africa.
Oh wow, that's a very interesting list of your top 5. Oh, nice. So I'm sure that some of our listeners who would align with you very strongly on your movie choices, but I do like them. Okay, now, so we'll go into the second part of our fun question, and that is this or that. So this or that quiz, but it's still focused on movies. Are you ready?
Yeah.
Okay, action or drama?
Drama.
Sci-fi or fantasy?
Fantasy.
Plot twist or predictable but satisfying ending?
Satisfying ending.
Okay. Musical or straight drama?
Straight drama.
Watch in a cinema or stream at home?
Cinema.
Okay. Based on a true story or pure fiction?
True story.
Okay. And with that, we have come to the end of our podcast today. Thank you so much, Michael, for being our guest and just sharing on what the world needs to do. And even as we rethink the state of global public health, how can we move it to where it's more equitable, where it's resilient, and where it serves everyone regardless of who or where they are? It's been such an honor having you on the podcast today.
It's been my pleasure. Thank you very much.
Thanks for being part of the global public health revolution. We hope today's conversation left you inspired, challenged, and ready to shake things up. If you loved this episode, don't keep it to yourself. Subscribe, leave us a review, and share it with your network. Let's keep the momentum going. This show was produced by Dennis Nazarov and AHF Global Communications and edited by Resonate Recordings. Want to learn more? Visit us at aidshealth.org or join the conversation on social media on X, AIDS Healthcare, on Facebook, AIDS Healthcare Foundation. Until next time, keep pushing boundaries, amplifying voices, and keep the revolution alive in 2025 and beyond.